In our IC. In fact, there was a talk of Dr. Kamal B. Kapoor also over here. Maybe we can take in between or at the end of this. So this IC instruction course is for the phakic lens use and how to begin and what are the indications, what is the best available technique, and how to proceed and how to see the complications and how to manage them, and what are the ancillary things which has to be seen post-operatively, and early detection, and what are the new things in this phakic lens technology. So I am Purendra from Gwalior, and with me my course. Can I have my slides, please? With me, my worthy. No, Dr. Kamal has not come. So let us begin with our IC, this one. So, Phakic IOLs, learn it from the masters. And welcome to this beautiful venue, and very, very good morning to all of you. So, I will be speaking on introduction and overview of Phakic IOL, and then in continuation, I will go further and pre-operative planning and workup. With me, our president of AIOS, Dr. Partha Vishwas is there, which will be speaking on the correct way to do ICL and toric ICL. Dr. Mahipal Sajdev will be discussing and giving light on intraoperative and early post-operative complications in phakic IOL and their management, and challenging situations of phakic IOL, and experience will be dealt by Dr. D. Ramamurthy. Experience of presbyopic phakic IOLs will be shared by Dr. Titial sir, and with me today, Dr. Sudhank Bharti, Dr. S. Bharti, another master and experienced surgeon in cataract and refractive surgery. So he will be sharing his experience on long-term results and issues of phakic IOL. So we all know all these star instructors, star performance. So I will go further to our talks, and overview is that we can correct refractive errors by surgical methods or non-surgically, and we'll be focusing on surgical method, which are LASIK and cornea based, and the lens based, which is refractive lens exchange or clear lens extraction, and phakic IOL. So phakic IOL is implantation of the lens which is a biocompatible lens in front of the natural lens of the eye to correct the refractive error. And they can be angle supported, iris fixed, or the posterior chamber phakic IOLs. So we will be focusing on the posterior chamber phakic IOL here, and various designs have been developed in last almost 60, 70 years, and which were failed. And this was the design which I was discussing just now, VeriSize, which was made up of the PMMA, and but many issues like corneal decomposition and many were there. This is now out of vogue, and so various designs. At the present day, phakic IOL, which we are using behind the iris, is based on the design given by the Fedorov in 1986, which was collar button or mushroom configuration. Just to give you the insight, this is a small video of less than 50 seconds. The incision of 3.2 millimeter or 2.8 millimeter is given. Fill the chamber with viscoelastic, which should not be overfilled, and the lens is loaded, front loading system, and slowly it is pushed into the anterior chamber. And this is the spatula, lens managing spatula, and the 4 haptic or plate haptic design. The haptics are pushed behind the iris like this, and even the toric design is used, and then by any means you can remove the viscoelastic from the anterior chamber. Mind it that our crystalline lens is still there, and it is clear, and we should avoid jerky movements. So the advantages of corneal refractive procedure are that over the corneal refractive procedure is it preserves the corneal integrity. So we can do it on patients which are having thin cornea or irregular cornea, or due to some reason they have chances of ectasia post-operatively. So the cornea is not suitable, that in such cases we should do ICL, and this is a reversible procedure, and maybe due to some reason it gives us an option to reverse it, to explant it, or to exchange it. And we can correct high refractive errors, like with LASIK we can correct up to 6 to 7 or 8 diopters maximally, but here we can correct up to 18 diopters, and with some lenses we can correct up to 25, 26 diopters, or maybe we can do bioptics to correct the refractive error. And in hyperopia also, if the anatomy is suitable, then we can do it. And there is because we are not cutting the corneal nerves largely, so the chances of dry eye development are unlikely as compared to the corneal surface procedure. The anatomical advantages are there, that it is placed behind the iris, and because of this it is not visible to someone. So therefore it is gives an excellent cosmesis, like iris claw or the anterior chamber lenses. It is far from the endothelium, the chances of damage to the endothelium are not there, and it is close to the nodal point of the eye. So there is a gain in the retinal size image. So we have seen that in most of our patients there is improvement in the vision and Snellen's chart vision, and it is located in the sulcus, which has a stable location, and therefore we can do toric the correction also, and there is no fixation to the iris tissue. So this table is very important for us. So which tells us in the first this thing you see about the ICL, which is the gold standard, which comes from the Star Surgical Vision ICL, it is called now, and we can correct up from plus 10 diopters up to minus 18 diopters range, and we can also correct up to 6 diopters of cylindrical power too. So it is in post-keratoconus cases, stabilized cases also it is useful. It comes in size from 12.1, 12.6, 13.2 and 13.7. The material is very, very important, and I would like to highlight it, that it is made up of a collamer hydrophilic porcine collagen, and this is a hydroxyethyl methacrylate copolymer, which differentiates it from the rest of the lenses, which are hydrophilic acrylic lenses, and they are available in our country, in India, from various group. So the second one is from the care group, which can correct from plus 15 diopters up to minus 30 diopters. I have used up to minus 26 diopters, and with 6-7 diopters correcting cylinder. So this is comes in 10 diopters correction, and the size also can be varied from 11 millimeter to 14 millimeter in 0.25 millimeter steps. Another is from the Appasamy group, which can correct up from plus 10 diopters to minus 23 diopters, and various steps from 11.5 to 14 millimeter. And lastly is the iCryl from Biotech, which can correct from 0 diopters to 23 diopters in 0.5 diopter steps, and the size from 12 to 13.5 millimeter. All these three lenses are made up of hydrophilic acrylic material, with which the IOL is also made. So coming to the design, there are certain specific things which are special to these lenses, that it has a central vault. So central vault means, as you can see below, there is a hump or there is a convexity which is predetermined and pre-placed in the lens. So lens come like this and it remains like this. And very good morning. Another, please come here. Dr. Ramamurthy is here, our star performer. And this is a foldable lens, and this vault accommodates the convexity of our crystalline lens. So this is a foldable lens and it absorbs a UV radiation, but important thing is the sizing. So advantage of this material from the Star Surgical is that it is a polymer material and it attracts fibronectin. There is a layer of fibronectin which is formed on the surface and which repels the proteins, so there is no less chance of protein deposition on the surface, and thus polymer lens is not recognized as a foreign body and there are no deposits of material on the surface, unlike the hydrophilic acrylic material. And above all, this material has a maximum light transmittance. So another good part is that now these lenses come with the central opening of 360 micron in diameter. In previous generation lenses, and in hyperopic cases, we have to make a peripheral iridotomy. But with these lenses, newer generation lenses, we have a 360 micron diameter central opening, which maintains the natural aqueous flow around the lens, crystalline lens around this lens, and therefore it eliminates the need for iridotomies. And the perioptic ports are also of the same size, which gives us the advantage of removal of the viscoelastic material from behind the lens, and it provides a redundancy for the central optic part if it gets occluded at any time by the proteins in the aqueous, but which is very, very unlikely to happen. So this new generation ICL, which I said, which is a gold standard, it has a central optic zone of 5 to 6.5 millimeter. In the range of 0.5 to minus 14 diopters, the central zone is of 6.1 millimeter, and above it, it is of 5 millimeter optic zone. So this large size optic helps in reducing the glare in halos, and particularly during the night time, and this is especially important in young males who do the night driving. So the newer generation presbyopic variants are also available. The Evo Viva ICL, which comes from the Star Surgical, I don't have any financial interest, is based on the EDOF platform, while the Indian counterpart from Care Group is a refractive optics, and it gives an add of near add of +4 diopters, and you can correct the